try to, we're just trying to kind of get everybody as educated as possible. Just picking some basic stuff. So STEMI was one that just thought would be appropriate for me. Maybe we'll do one for Taber, and then Hammock was going to maybe do one. I'll talk with him after we're done, just to make sure that that's getting started as well. But just kind of the very basics of like a STEMI case, and kind of pre and post management and that sort of thing. And if there's anything that you want to ask that I didn't talk about, feel free. I mean, again, it's just kind of like basic stuff. I got rid of a lot of stuff about reading the EKGs and stuff like that. It's more like, what are we doing? Why are we doing it? Stuff like that. So, like I said, go over the basics, some of the stuff from the guidelines, review a case from here, talk about cardiogenic shock for just a minute, and then stuff that can go wrong. Why do we care about STEMI? It's a medical emergency. I think one very humbling thing that I've learned after doing this for 12 years, there's really just no such thing as a standard patient. Every single one of them is different. Sometimes they are completely stable despite their LAD being occluded. Sometimes their diag occludes. It's like a small branch and they code. Be talking to them, 1 second, the next minute they're in B-fib. It's just, you just can't predict it at all. So really, care of a STEMI requires all the teams, the ER, cath lab, and CVU to be firing on all cylinders and kind of be prepared for everything. Blessing serves 13 counties for the most part for STEMIs. We're the biggest hospital in 100 miles. We do about 100 STEMIs a year. We are now competing with another close facility that's really trying to, build up their cardiovascular program. You can see how happy they are. It's amazing over there. It's like Shangri-La. So maybe we can get there sometime. Recognizing people there, I think. So what is a STEMI? So STEMI is a clinical syndrome defined by characteristic symptoms of ischemia and association with persistent damage. So there's damage happening to the myocardial tissue. You're going to see elevated cardiac enzymes. The EKG is going to show, sorry, I have to move this so I can see. ST elevation greater than 1 millimeter and at least 2 leads. If you're going to the precordial leads like V2, V4, V5, those leads have to be up to 2 millimeters in men and 1.5 millimeters in women. You want to see 2 leads in a row. You don't want to see one to call it. And that's based on the guideline. Trying to right here. The other thing to be aware of is if we did nothing, if we just let it kind of complete itself, then it's going to be a Q wave MI. So we used to call these 25 years ago, a STEMI was called a Q wave MI because they would ultimately their EKG would show the Q waves because so much damage was happening. It's about 1/3 of MIs, with 2/3 being non-STEMI. One important thing to be aware of is the vast majority of cases, the vessel is 100% blocked. There's no flow at all in the vessel. The remainder, in my experience, it's at least 90%, 90 to 95% blocked. But most of the time, it's 100%. With the ST elevation going on, that the real term for that is injury. So the heart is being actively damaged while the STEMI is occurring. So mortality of a STEMI is about 5 to 6%. In the current era. If they have shock, meaning blood pressure less than 90 or MAP less than 60, and then other signs of shock like cool extremities and a lot of times altermentation, it's extremely high mortality. It's 50%, which is why I groan when I get the call from we have a 95-year-old and our blood pressure is 60. It's oh, geez, because it's not going to end well. I mean, we try, but a lot of times those are kind of very tall odds to fight. So the STEMI, you're gonna have 100% blockage of the pipe. Non-STEMI might be about 85, 90%, something like that. It's just usually not 100%. There's usually some flow. This is what STEMI looks like by cath. This is where the LAD should be after they've stented this artery, and now you see the LAD has come back. Any questions about anything so far? No. So one question you might ask yourself, is it even a STEMI? So you may have an EKG happening on the floor that's really concerning you. One thing I would encourage is kind of just an old adage is really don't go by the telemetry. You shouldn't get too excited about the telemetry showing anything. You really got to get the 12 lead because the telemetry is only one lead anyway, and you have to have the contiguous lead showing the ST elevation. That arrow is pointing to what a Q wave looks like. So a normal EKG would not have a Q wave because that indicates that the scar is happening. The Q wave will pop up in about, they say, hours to days. So if somebody's heart or somebody's artery occludes, that Q wave may be there in about an hour or two. So it doesn't mean that you can't do anything, but it just means that there's some infarction happening. The ST elevation, on the other hand, occurs immediately. As soon as that artery occludes, the ST elevation occurs. So we see often in the cath lab, like when we balloon an artery, that's when the balloon is up, we see ST elevation, and it goes away when we come down on the balloon. So that that's going to show up basically right away. Injury, again, that implies that there's ST elevation without Q waves. That occurs, within seconds to minutes. Infarction, when you hear the term infarction, and sometimes the EKG will say infarction on it, that is something that is done. Infarction has happened already. There's already scar tissue there. That implies usually there's going to be Q waves. So if you see Q waves and ST elevation, it might read out as recent or acute. If you see T waves that are inverted as well, probably that's a done deal because the T waves don't invert until, 3 to 5 days after the MI has occurred. So if they come in and they say, I've been having chest pain for a week and I just had some time today, so I decided to come to the ER, which unfortunately that happens all the time. If you look at the EKG and their T waves inverted, probably there's not much you're going to be able to salvage. You probably heard reciprocal depression talked about. This refers to depression of the ST segments in non-infarct leads. If you see reciprocal depression, it's a very strong indicator that there is a STEMI happening. So if you look at this example, 2, 3, and F are elevated. That's where the injury or the STEMI is occurring. And then the reciprocal leads to the inferior leads are the high lateral leads. 1 and L are depressed. So that's the reciprocal depression. One thing you might hear, well, there's no reciprocal depression, so I'm not going to call this STEMI. It does not have to be there to call it, but if it is there, it is almost certainly a STEMI. So it helps you if it's there. If it's not there, it doesn't mean it's not going to be a STEMI. You got to take it seriously. Another thing that you can look at is convex or concave. So, and this was a study where they basically, if you draw a line from the J point to the T wave, and if the ST segment is below the line, that would be considered concave. And if it's above the line, that would be considered non-concave or convex is what we more often would call it. The convex is the one that's more concerning. So this study, they basically kind of like took a bunch of patients that came in with chest pain and they reviewed their EKGs and they correlated, did it end up being a STEMI or not? So if there was convexity, that was about 77% sensitive for it. So it would only miss about 23%, but also if it was there, it was like 97% specific. So if it's convex, it's most likely going to be a STEMI. Again, it's highly specific, but it doesn't have to be there. Does not have to be convex for it to be a STEMI. Another quick and dirty thing, once you've gotten your 12 lead EKG, you draw a little face on there. Kind of looks like it's not too happy face with the convex STEMI. Whereas this would be like early repole, it doesn't really, it looks like more like a smiley face. Okay, any question about any of that? So probably, as far as nursing wise, you guys are not going to be required to be calling the STEMI, but I would say if you're worried about it, get the 12 lead at the very least. No one's going to be mad if you get a 12 lead before you call. You got a 12 lead, can you look at it? Other things, left bundle branch block for a long time was considered a STEMI equivalent. So a lot of like cath labs were activated regarding a new left bundle, but they de-emphasized that in 2013, and they recommend using like a set of criteria, which you're not going to have to remember, but it's called the Scarbosa criteria. If the patient has a left bundle branch block already, it does make diagnosing a STEMI more difficult. So what you really look for is excessive discordance of the ST segment with the QRS or concordance. So excessive discordance or concordance. So what does that mean? Really, basically, if you look at the QRS, this would be the QRS portion of the tracing and it's going negative. So discordance would be the ST segment going positive, and it has to be excessive, like typically like 5 millimeters or more. And then the other thing that you look for is concordance. So anytime that if the patient has a left bundle and the ST segments are going the same direction as the left bundle, that's concordance, and that would be considered bad. So that would be how you get to meeting Scarbosa criteria. Another thing that is commonly talked about is like ST elevation and AVR. So sometimes the patient will come in with, fill in the blank. They coded, they're hypotensive, or they're having chest pain, and you see ST elevation and lead AVR only, and then you see ST depression kind of like V1 to V6. And that can be a very bad, predictor or coronary finding for left main disease, but it's not specific. So what it really means is that they're circumferential, like the whole heart is ischemic if you see ST elevation and AVR. So it can occur with an MI, but other things that it can occur with, it's just somebody that had a cardiac arrest. They got hypoxic, they got hypotensive, they were coded, and then they were resuscitated. Now they may have ST elevation AVR. Septic shock, came in with a UTI, their blood pressure 60, and they are on some Levophed now, and you see the ST elevation. So you got to kind of try to really dig what happened first. Did they have chest pain first, or was their COPD flaring up and they got hypoxic and coded? So it's something that we're aware of. If they have ST elevation AVR, the one kind of bedside thing would be you don't want to give Plavix. You don't want to give Plavix or Effient or Berlinta, because that patient may have left main disease and then they're going to be sat on for a week before they get their bypass surgery. So we've seen that happening a couple of times. So in the ER, we would not want to give the Plavix if they have ST elevation AVR only. Another thing that I kind of look at is like, this would be kind of like if you're on the floor and because I get calls all the time. This patient's having chest pain. I think they're having a STEMI. Well, what are they doing? They're sitting there watching Bonanza, eating a cheese sandwich. And I get there and they're like, got their feet up and they're just watching TV. Probably they're not having a STEMI. So like, if they're there for some other reason and they're comfortable and, you're looking at the telemetry and it shows ST elevation, I wouldn't really drill down too much on that. You really want them to have some complaint that, this happened 2 weeks ago. A patient was post PCI. I was sitting in the CVU and I got called back. He's having crushing chest pain. It's 12 out of 10. So I came in at 5 o'clock on a Saturday, and the guy's sitting there watching TV, and his sister's feeding him pudding. He's got a big smile on his face, and I'm like, "You look pretty comfortable," And he didn't have anything going on. So there's some quick hits. We talked about mortality in the STEMI era, and the current stent era is like about 5%. Primary PCI or stenting basically is the preferred way to fix the STEMI. Used to be thrombolytics until like 1994, 1995 range. It's also a class 1 indication to do an angiogram basically from the ER if they had an out of hospital arrest and then their EKG shows a STEMI. Ideally, we used to say door to balloon, but now we talk about first medical contact to device. Doesn't exactly roll off the tongue, but door to balloon or first medical contact to device 90 minutes, really like first medical contact meaning as soon as they got there, as soon as they saw somebody from the ambulance or, showed up in the waiting room or that sort of thing. Looking way back on STEMI. So I think it's kind of interesting to understand what used to be done. Like EKGs came out in about 1913. Is when they first came up with EKGs, and that was kind of when they first determined what a STEMI probably mean, is on the EKG probably means there's an occluded artery. So in the 20s, they basically gave the patient morphine. In the 30s, they were able to give them oxygen and they gave them some sedation, probably morphine, probably some heavy duty narcotics and just have them stay at home. In the 50s, the state of the art was 4 to 8 weeks of bed rest. And in the 1950s, they started to talk about streptokinase, which was one of the first treatments, like a clot buster, was streptokinase, kind of like TPA. In the 80s, we start getting beta blockers and aspirin. So the 1986 beta blocker, 1988 aspirin. 1985 was when use of thrombolytics was proven to actually be helpful to open the artery. And then in the kind of late 80s, early 90s is when they really drilled down on kind of at that point balloon angioplasty versus giving the patient thrombolytics. This was just an old study from 1952. So armchair treatment of acute coronary thrombosis. Basically, this was a study about, does it help to sit them in an armchair rather than have them lay in bed, rather than have them lay in bed for 3 to 6 weeks. So, and they were giving them also in this study, they were giving them basically digoxin, warfarin, and heparin. And they concluded that sitting upright had no complications and was superior to having them lay in bed for 3 weeks, and it helped the patient's morale. So obviously that's kind of far from what we do today. We send them home usually in 48 hours. So this is a case that we did, I think in 2018, 73-year-old man, no prior cardiac history. He's got hypertension and GERD. He came to the ER with chest pain. While in the ER, he had 2 VFib arrests, but after being shocked, he was awake and talking. He admitted that he was having some exertional chest pain for about a week that he was trying to ignore. He's still complaining of severe chest pains, and here's his EKG. So everybody see any issues going on there? Look okay. So what's going on? STEMI, activate the alert. B, LVH, get cardiac enzymes. C, early recall, send him home and tell him to call his PCP on Monday. D, hyperkalemia, call Dr. Tanios. E, probably lingering, call psychiatry. Anybody want to take a stab at what's going on? Somebody. Shout it out. So STEMI, why? What do we see on here? Yeah, so we see the reciprocal depression, right? We see the reciprocal depression, the inferior leads. We see the convexity. It's pointing upwards. I mean, this is like tombstones. This is like as clear as you get. And yeah, it doesn't look too happy. So in the ER, what are we doing? We're going to alert the on-call interventionalist and the cath lab team. We're going to want to go to the cath lab. It's a class 1 indication to do a PCI if they're within 12 hours of their symptoms. So there's, as symptoms go along, and one of the kind of the hardest lessons to learn, if they come in a day late or even like 12 to 18 hours late, they also don't do so hot. So, I mean, the guidelines say within 12 hours, it's a class 1. If you're more than 12 hours, you want to have a reason to go to the cath lab. So are they still having chest pain? Are they still having ST elevation? The other thing would be if they're hemodynamically unstable, really that time frame doesn't really apply. You have like up to 36 hours. In the ER, want to make sure you got the IVs in. You want to, if you can, shave the groin. You want to place defibrillator pads and monitor as soon as possible. There was a recent case that we had where it was an anterior MI and he didn't have his monitor on, and he was coding and we didn't really know what the rhythm was. So as soon as you can, we diagnose a STEMI, as soon as you possibly can, let's get the monitor on and get the pad done. Because again, and this guy, good example of somebody who kind of just goes south real quickly. He's like, can I go home tomorrow? I want to see the football. I want to see the Quincy football game. And I'm like, well, we'll see how things go. And then 10 minutes later, he was getting chest compression. So, and then we want to give the STEMI appropriate kind of upfront medications in the ER. What would that be? What medication we want to give in the ER? What was that one? And aspirin, heparin. You can give morphine, you can give oxygen. Usually we're given like Plavix or, the kind of the similar medicine, be Plavix, Brilinta, Effient. There's always this huge push to give nitro, and it's in the guidelines. It's kind of like in the even the ACLS guidelines, but more nitro helps the chest pain. It doesn't help anything else. So I'm not too keen on nitro, especially if their blood pressure is already low. I'd almost rather have them give morphine. These are the medications that are considered class 1 to do right away. You want to do aspirin, you want to do your P2Y12, so Plavix, Effient, Brilinta, which those will be continued for about a year. We're going to want to give the heparin bolus. We're going to want to give, you can give the beta blocker, especially if they're really hypertensive. So in the CVU, you're going to see that within the first 24 hours, we usually give beta blocker like metoprolol, and then an ACE inhibitor and statin. Optional meds, probably not going to worry about these too much because we kind of do these in the cath lab, would be integralin, some IV beta blocker you can do if their blood pressure is sky high, that sort of thing. So what P2Y12 inhibitors, these are your Plavix, your Brilinta, your Effient. The way they work is that they block the P2Y12 or the ADP receptor. And what that receptor does is if the ADP receptor is activated by and not blocked, inside the platelet you get release of all these granules, and those granules are basically like super thrombogenic. So thromboxane is released, and then you get upregulation of this receptor, which is the 2B3A receptor. And this is where the fibrin will connect with the platelet. So this is where you start getting the first clot, is the platelets, and then they connect with the fibrin, and they form the initial clot in the vessel, which is the white clot. Ultimately, you get red blood cells and fibrin and everything, and then it becomes more of a red clot. But the first clot that we get to right away, it's more, and we actually suction it out, it's white clots, platelets. So that's why we want to block the P2Y12% to prevent the platelets from cross-linking. From my perspective, Plavix is reasonable in most patients, but all three of those drugs have class 1 recommendations. The newer drugs are more costly. So, some people do use Brilinta and they give it down to the ER, but then we drilled down like 3-4 years ago to see how many people actually left on Brilinta, and it was like half. So they can't, because they can't afford it. And then sometimes they will be like, well, I figured I'd just take it in the morning. It's supposed to be a twice-a-day drug. So that's why I don't use it that much. Both of the newer drugs, the Brilinta and the Effient, they do reduce like cardiac events, but they have more bleeding. Like I said, the Brilinta is twice-a-day dosing. And the other thing it does is cause shortness of breath. So that's like a classic story of somebody that gets Brilinta, they come back a week later in the ER, I'm short of breath. And then like the whole thing is started over again because their EKG kind of looks funny. And then the cath lab's called in and it's like, well, you're just short of breath from Brilinta. And then one thing you got to remember, you can't give Effient or Prasugrel in patients over 75, or if they have a history of stroke, or if they weigh under 60 kilograms. So I think we're getting back to the patient. Time to get the pipes open. Like I said, lytics are good. Lytics work okay. PCI is obviously better. This was like the quintessential study on comparing the thrombolytics versus stenting. It's 23 trials, where actually it's more like balloon angioplasty for the most part. But patients that got balloon angioplasty had lower mortality, lower repeat MIs, and less stroke. So like if you look at like the whole thing together, actually the numbers aren't as big as you might think. Like in my head, like stents are way better than thrombolytics, but it's really only about a 5% difference of death, MI, and stroke. And the main thing you're reducing is the bleeding strokes. People that get thrombolytics, there's like a 1 to 5% chance that they have a brain bleed. And we actually saw that recently. There was like a 37-year-old guy that came in and got thrombolytics, I think in a line eye. It wasn't my case, but then he ended up having a hemorrhagic bleeding and he got flown to Springfield. I think they'd opened his cranium. So yeah, thrombolytics are kind of have their hangups. So stenting is way better. So just kind of clarify, balloon angioplasty, and that's just basically blowing up a balloon in the artery, and then stenting is a balloon with these kind of little springs or metal cages that are mounted on the balloon. You blow up the balloon, you come on out, and then you have this piece of metal sitting in the artery, and that piece of metal will sit there and be exposed to your blood for somewhere in the range of 3 to 6 months. If it's a drug-coated stent, about 4 to 6 weeks if it's a bare metal stent. So that's why we really, really want the patient to get the antiplatelets. That's what a stent looks like, deflated and inflated. They're tiny. We think they're big when we look at them on the screen, but they're tiny. They're like, if you take apart a pen and take that little thing out, little spring in there, that's about how big they are. Radial or femoral, should we go radial or femoral? Femoral's preferred because it's faster and we can place a balloon pump. B, radial's preferred due to bleeding complications reduced. C, dealer's choice, they're the same. D, I thought this was going to be a lecture on colostomy bag. Anybody have any thoughts there? What's safer, femoral or radial? Yes, radial is way safer. There's a bunch of trials that were done. Not that you would have to memorize any of these, but as we go down the line and we get kind of further along, like the STEMI radial trial showed the bleeding events were cut from like 8% down to 1%, and mortality was also reduced by about 1%. So like there may be a benefit to longevity in the patients if we go radial. And then, you know, they did a meta-analysis of all the trials that were done, and there seems to be a reduction in death by going radial, and then also bleeding. One thing, this is kind of off topic, but it's just something that's come up lately. Let's say you get a patient on the floor and they have a TR band on, and you let some air out, and it starts to like bleed. What should you do? What's that? Yeah, put air back in. Just put back in whatever air you just took out. Gotten a lot of kind of little unusual calls. Like when we took it and we took the air out and it started to bleed, so then we put another one on. It's like, just put the air back. I mean, those things can stay on for 24 hours. Doesn't matter. You have blood flow coming in the other side. And that's one of the reasons it's so safe, because you have like redundant blood flow to your hand. So you can leave that thing sitting there. It's not going to hurt them. You know, just leave it and leave it all night for all we care. It'd be better than getting hematoma. So cath lab looks about like this. You know, we stand on the right side of the patient. We're either in the femoral artery or the radial artery. We are only pretty much looking at what's going on the screen. This was our patient's angiogram. So it's pretty bad. There's a lot going on, but the LAD is gone. So that's right here. The LAD comes to a complete stop right about there. And the other thing that we see is that the heart is auto bypass. So we have blood flow coming from the left side going and filling the right side. So we know that his right coronary artery is gone. So yeah, there's his right coronary artery. So that's just gone. So we basically put a wire down. We ballooned somewhere in this range. So this was the artery after we ballooned. There's a stent going in. There's another stent going in. And there's the LAD back. So that's what it looked like after we got the blood flow. And we came back a couple of days later because you can also see here is his ramus artery has like a, like 80–90% blockage, and the circumflex also has some disease in there. So we worked on that as well. So there's the stent going in the circumflex. There's a close-up on that ramus vessel with a stent going in. And then here's the final result. So we got basically all the left side of the vessels back open, and the right was a chronic occlusion that we just managed medically. I think I still see this patient, so he seems to be doing fine. What was I driving at here? This is something that used to happen kind of on the different floors, maybe not so much the ICU, but again, we've got a piece of metal sitting there in that artery where your blood is going to hit it, and your blood's going to want to start to clot. So these are some of the things that I've heard. The patient's NPO, so we didn't give the aspirin Plavix this morning. Well, then you better put an NG tube in. It's an emergency. The patient needs to get that. Needs to get the aspirin Plavix. The patient has not passed the swallow study. Again, you can put an NG tube in. The patient refused it. Has happened. If that's the case, let us know. And we can start some IV medications that can take the place. Also give them a rectal aspirin, and then maybe they will stop refusing it. Blood positive, so we didn't give it. Again, you can live with a occult blood positive. You can't live if your stents include that the mortality is like 50%. It's very bad. So basically, the bottom line: holding antiplatelet therapy after a fresh stent is a life-threatening emergency. So try not to fall into those kind of traps.
You're talking fresh stent. Are you talking still during their stay? Or are you talking if they've come back into the hospital?
Anytime within the first really 6 months, they really should not miss it. And that's another thing that'll happen too. It's like, we didn't get their med rec yet, so we're holding off. And I've seen patients even last week, a guy that we had freshly stented, and he was back with like some renal issue. And it was like 3 days into his stay, and he wasn't on anything, not even his aspirin. So, I mean, I sniper fired those in there, but. This is our new STEMI patient satisfaction survey. All right, couple of things on just like STEMI shock, which is just another, bane of all of our existence, but there are some things we can do. What do you want to do if they remain in shock? You want to max out pressors, put them on levofed, put them on dopamine, dobutamine. You want to put a balloon pump in. You want to place a LVAD, basically a Impella. You want to send the patient for cabbage. Everybody knows that's probably not going to happen. If they're in shock, they're probably not going to cabbage. So basically, shock is very bad. Shock would be considered hypotension, blood pressure less than 90, or on pressors. So if they're on pressors, to keep that blood pressure at 90. MAP less than 60, cardiac index less than 1.8. So we're not going to be getting that number unless we have a Swan in, or if we have the Cheetah device hooked up, but it is another kind of number we can look at. A lot of times they will be altered metal status, they'll be going into renal failure. Another thing that kind of over the years has made it clear to me is that they often are pretty loopy. Like they're on the cath lab table, we're trying to get their artery open and they just aren't listening. They're trying to sit up, when are you done? When are we going to be done? They're probably going into shock. And so I try to have a lower threshold for basically calling anesthesia to come intubate those people because they're headed in a bad direction when they start acting that way. Cardiac perfusion drops, when their blood pressure drops, that further decreases cardiac output. It becomes a vicious circle. Typically, shock will occur when 40% of the ventricle is compromised. So usually it's just LV failure, like the LAD or multivessel on the left. It's the main cause of early mortality in patients with STEMI. The main goals are to get blood flow restored, and then it's important to be aware. We use these tools. We use balloon pump and we use Impella, but there has been no improvement in the mortality rates of cardiogenic shock in the last 20 years. Balloon pump is something that can still be used. What is a balloon pump? Basically, we put it in from the groin. During diastole, so when the heart is not pumping, the balloon inflates with helium. So that kind of like puts back pressure on the coronary arteries. It supposedly helps a little bit of forward flow via like a vacuum effect when it's deflating. So maybe like at most, maybe a 20% effect. Very modest enhancement in cardiac output. You have to have an EKG working. You have to have an EKG working for the balloon pump to work because it will cycle with the EKG. So they studied this. They took 600 patients with acute MI and shock, and they treated 300 of them with a balloon pump and 298 with medical therapy. And about 15% that were getting the medical therapy crossed over to getting a balloon pump. And then, suffice to say, kind of the doctors at the bedside, 10% of the time they thought, even though they weren't randomized to getting a balloon pump, they still did it because they thought it would help the patient. And what they found was if you follow it out to 30 months here, there's absolutely no difference whether they got a balloon pump or whether they got medical therapy. So it's kind of confusing. There was another trial that was a little more specific. It was like 340 patients with an anterior MI that were randomized to a balloon pump or no balloon pump. And they didn't see an effect on like the infarct size, but they did see that at 6 months, 3 patients in the balloon pump group died versus 9 in the 9 in the medical group. And then if you combine death, shock, and heart failure, it was 8 versus 21% favoring balloon pump. So this was kind of big anterior wall in my patients. So there's still some reason to use it. I seem to see that it turns them around a little bit sooner. What about like the Impella? So this is what PVADs looked like in like the late 80s. So this is probably an ECMO, I would say. So they're kind of pulling blood out of the vein, they're oxygenating it over here, and they're pumping it back up into the artery. So we've kind of come a long way from that. This is what an Impella looks like. Much smaller, much easier really easy to put in there. The other good thing about Impella is that over the next year or so, they're rolling out a 9 French one. So the one that we have access to now is about 13 French. So they're getting a lot smaller. That'll be better for the patient because it will be less likely to affect their legs. This is what the device at the bedside will look like for the Impella. An important thing from my perspective is there's always a phone number on there if you're having trouble with it. The company does support it 24/7, so you can always call and say, here's what alarm I'm getting, and that way you don't have to call me. They'll take care of it at night. It definitely increases cardiac output more than a balloon pump, and so we probably all would think that this is going to make some kind of difference. But when they did a study with balloon pump versus Impella in a pretty small trial, about 50 patients, at 6 months, there was no difference in mortality for Impella versus balloon pump. So, I don't know. It's one of those things, very expensive. It's like $25,000 for the Impella. The company sure wants us to think it does a lot. Sometimes we do it because there's really not much else to do. I mean, we're just trying to do what we can, but the other thing about it is it's very large. So it's like 13 French. You have that sitting in like, a small lady, it's going to be including their leg artery. So they end up getting bleeding and like ischemic cold leg kind of complications. This is just that study kind of, it's like the exact same mortality rate, balloon pump versus Impella at 6 months. What can go wrong what can't go wrong? My God, we've seen everything. Groin hematoma, arrhythmia is big. What arrhythmias are we going to see? What'd you say? Yeah, VTAC, VFib. VTAC is probably more common. Almost always, you'll see some runs of ET in the first 48 hours. In fact, the whole reason that CVUs exist is because of the arrhythmias. The early protocol would be they would put everybody on lidocaine, and then they would monitor them in the CVUs, and that's when the CVUs all popped up in like, I think, early 80s type of thing. So yeah, arrhythmia, we don't really react that much to like short runs of ET in the first 48 hours. If you get beyond 48 hours, then that patient probably needs to have an ICD before they go home. Groin hematomas obviously are, a complication that can happen with any kind of PCI. Ongoing chest pain. So another scenario that has come up lately, so-and-so had a stent, it's 5 hours later, and there's some complaining of some chest pain. So at the bedside as a nurse, what do you want to do before you call the cardiologist? Sometimes I get an EKG. The main reason that we order an EKG right after is because we want to have something to compare it to. So you'll see that after every PCI, there's an EKG. It's not because we think there's a problem. It's because we know there's not a problem. So let's get the baseline. And then yeah, again, we're never going to be mad if you call and, you say, I got an EKG. It looks like, it looks about the same or it looks better. That's going to be pretty reassuring. In the first 24, really in the first 2 months, the way that a stent is going to close is not going to be subtle. It's going to be filled with clot. So if you call, and the EKG looks exactly the same, chances are we're probably not going to do too much, but definitely get that 12 lead. Other bad things that can happen are mechanical complications. So these are often patients that ignore their chest pain for a while. So mitral papillary rupture, we had one of those last year. We tried to get him on a LVAD, and I think he passed away at bedside. Wall rupture, again, actually we had one of those too. That guy, I remember, I think you were there. I think that guy was like a Monday after Thanksgiving, and he was coming from outside facility. He had sat through the whole weekend with his chest pain, and he got TPA, and he showed up on a Monday or Tuesday, and literally just heart exploded when he got here. So this is the kind of thing that happen if you wait, and it's almost like a historical perspective or perspective of patients that don't seek medical care. It does not go well. So we try to talk our patients into. I always try to tell them after in the office, if you have chest pain, go on right away. We'd rather find out that you just have heartburn than to miss something. So take home messages. I don't even remember what I put here, but yeah, your STEMI is a true medical emergency. Everything that you can do as soon as you possibly can do it, do it. You can get the groin shaved, you get an IV in, get the pads on, cram the Plavix down their throat. You know, why? Because they might code. So, you know, like it'd be an issue, like they get upstairs and we have to do it through an NG tube. So it's better to just get it in right away. It's important to study the EKG carefully, but the clinical scenario trumps everything, meaning like they come in and they're having crushing chest pain and the EKG shows nothing. We're probably still going to take them to the cath lab. On the other hand, if they come in and they, you know, like I said, they're there for a UTI and, you know, we got the CKG and it looks bad. And that happens all the time. Like the residents will call me, I think we found a STEMI. Oh, why did they come in? Oh, they had a UTI. Probably not a STEMI, you know, let's go back and look at it. Antiplatelet medications are important right away and after the stent for at least 6 months while you have that kind of metal sitting in the artery. Ultimately, your artery will heal over it and then it just becomes part of the wall. And that's why we can usually get them off the Plavix by like a year. Priority number 1 is efficiently get into the cath lab, get it open. STEMI shock, highly fatal. A lot of what we do for that is just whatever we can, but it's not firmly evidence-based. A lot of new toys out there that might be the standard of care in the future, but the main way we know we can affect their mortality is getting the artery open as soon as we can. Any question about any of that?
Why
That's probably
Is it this is your brain on drugs?
Brain
Okay.
on drugs, yeah.
I am holding that to remember. I wasn't sure if that's what you were referencing.
Oh, that went longer than I thought. Chris got it. We're good. No question about anything.
When do you use Impella versus?
Very good question. You have to take it all into account. I would say me personally, if they are younger, if they have big leg arteries and they're in shock, then I would probably try to use the Impella. We did save that guy, you know, the one that I was talking about that we were chatting with and then coded. We did Impella first, and then he was like 50. They're 88-year-old lady or 85-year-old lady have tiny little arteries. It's hard to know. It's hard to make it to justify using Impella because the studies are negative on it. So if you might use the balloon pump on that person. There's no great answer. I think they're still trying to figure it out. But if we have the access and we can do, and it may be more so Impella down the, you know, within the next year because they're smaller. They're 9 French now, so a balloon pump is 7.
What's the your presser of choice for cardiogenic?
Levophed would be considered the presser of choice. They studied it versus dopamine, and it had better outcomes than current dopamine. So get my Levophed, and then you know how much Levophed. I mean, I probably wouldn't go much more than 10, 15, 20, because then you start getting like the rigid heart, and then then it can kind of make it worse. But that's another thing. There's no real study that shows the outcomes improve with pressor. They always like show that they're worse, but it's more like this patients are sicker, and that's why they needed the pressor, so they don't do as well.
If you get up to that, 10 to 12, 15, what's your next line?
Then I would say probably put on the cheetah, and then we can try to figure it out. I think it's good to use that because it could tell you, like, if the cardiac index is low, then they should do butamine, or maybe be the next one.
Maybe.
Or maybe that's going to be time to think about going down and putting pellet in and seeing if we can. You're getting into a second presser. Not good.
We got ER here. We've got a little bit of med surg here, CBU, PCU. Anybody else have questions
Yeah, I mean,
for you in certain areas?
Lately, there's been quite a few shenanigans with groins and radial
What
arteries.
kind of shenanigans are you seeing?
So just for the TR bands, don't be afraid of it. Starts bleeding, put the air back in. If you get a little hematoma, put another one on, and rest these. You can leave that thing on for 2 days. Doesn't matter. The hand will survive. So don't feel rushed to get it off. And then if they got a stent, likely they got heparin, they did get heparin or something. So don't start letting air out for a good couple hours. It's fine. You don't want to rush it if they have gotten blood thinners. The groins are just like an ongoing nightmare. All
What are some
around.
tips and tricks for the groins?
We talked about we were trying to put those mesh stickers on, but so manual pressure over the femoral head. Don't fall into the trap of, well, there's a hematoma growing, I'm just going to call the cardiologist. I can't hold pressure any better than anyone. That you can all hold pressure. So put manual pressure. If they're getting bradycardic or hypotensive, give atropine. You can put the top of the head down, and you can give saline. Do all those things and then call. Because you're their first line, that patient's first line. The low blood pressure from the groin is either a vagal reaction or an RP bleed. And there's no great way of differentiating that. RP bleeds, like a common misconception would be, well, I don't see hematoma, so it's fine. Well, that's going to be bleeding inward. So still hold pressure because you can still stop some of the bleeding if it's going retro. And then, give fluids, put their head down, give atropine, try to get it under control, and then call.
Are the fluids and atropine part of your post-cath work?
Yeah.
Then? It's all,
They are,
it's
yeah.
all and it's all pre-checked. Like when you put it
Yes,
in, you
yeah.
pre-check all yours. Okay.
Yeah, there was.
Just clarify.
The other thing I would say, if you're being tasked with holding the groin, make sure you check an ACT. One at less than 150, because it's going to be a long night. If you pull a sheath and the ACT is 300, better hope you have nothing better to do, because you're going to be holding pressure for a long time, or you got to put a time stop on, or that was one of the shenanigans that happened. Somebody called and said, hey, the blood pressure is 70, and there's a volleyball size hematoma right now. What was the ACT? Oh, I never checked it. Didn't check it.
Got anything else?
For STEMIs that come into PCU and are waiting to go to cath lab like the next day, what's like the probability that could then turn to a STEMI?
So
Is
that's a
it
good
common or uncommon?
question. And when we look at the non-STEMIs, I think from your perspective, what you really need to worry about is if you can't get their chest pain to go away.
Okay.
That would be the reason that we're probably going to still come in, because sometimes the non-STEMIs really are 100% blocked.
Mhm.
We can't get their chest pain under control, they need a cath. So don't feel bad about bothering the doctor with that.
Okay.
Even
Yeah, 'cause I see
even if I'm a jerk still on the phone, probably still should call, because if they're still having chest pain, something bad's happening.
Yeah.
There's injury or damage happening. And then what we often find ends up being a circumflex, because sometimes that's silent on the EKG. So that'd be the main one. What are the chances? I mean, if you get them on heparin and you get them cooled down a little bit, it's not terribly likely, but it's usually like if they're having chest pain at rest, it's usually like 95% blocked.
Okay.
Anything else that you guys would want to learn about that we could assign to someone else, or me, or?
I think you're gonna do a tavern one, didn't you?
I may do a TAVR one, yeah, sometime soon.
We have so many new people, and lots of floating staff members that are coming in and taking care of TAVRs. It would probably be
Okay, yeah, and then-
something to hear it straight out of your mouth is nice sometimes between you and Amy. It's always good information.
and I think Hammy said he was gonna try to do AFib, so I will, I'll tell him to get that cracking.
Do you, have you presented on EK? I know you didn't really do you didn't do a whole lot of EKG here. Do you or Hammock or any of you guys do that? I think that might.
I have a whole EKG talk on STEMI
Yeah.
diagnosis that I've done before.
Okay.
I have that, I can do that.
That would be something.
You set it up and just tell me where to show up.
Sure, yeah. So, yeah, let me set it up this time so that we know you're coming. But hey, I think we had a pretty good turnout for only Dr. Cook knowing that he was presenting. So it really worked out. And actually, if we can do it on nurse residency days, it worked out great. We have lots of people here. So thank you, Dr. Cook.
Well, maybe we can be as satisfied as those Hannibal nurses.
I did record this, so I will send that out, and I'll
Thank
put it
you.
on our Facebook pages and things like that. And then you guys that signed in, this will go in your net learning. It won't be CE for your licensure, but it is like contact hours for other things. So thank you guys for coming. Thanks.
Let me know when is the 8th, because I want to get them.
Yeah, absolutely. We'll there.
I think it is nice to do it on nurse residency days where I think it worked out great. You guys can come to.
Wait.
What to do for CEs, like to make sure they're where they need to be and things like that.
What's that?